Welcome to the BePure podcast. In this episode, we will take a deep dive into how hormonal contraception, like the pill, affects our bodies with Dr. Lara Briden. The period revolutionary Dr. Lara Briden is a naturopathic doctor and best-selling author of the books Period Repair Manual and Hormone Repair Manual. These books are practical guides to treating period problems with nutrition, supplements, and bioidentical hormones. With a strong science background, Lara sits on several advisory boards and is the lead author on a couple of peer-reviewed papers. She has more than 20 years experience in women's health and currently has consulting rooms in Christchurch, New Zealand. So we have her in our own backyard, New Zealanders. She treats women with polycystic ovarian syndrome, PMS, endometriosis, perimenopause, and many, many other hormone and period-related health problems. So welcome, Lara. It is an absolute pleasure to have you here.
Oh, hi, Lisa. Thanks for having me.
Oh, absolute treat. I have to confess, I have both of your books. I have two of each of them because I have one copy that I have actually destroyed with notes and with highlighted vivids. And then one copy that I'm happy to lend to friends and family that's not got all of my magical notes hidden within it. So thank you so much for gifting that to the world, because it's not only been great for me, but it's great for my clients, my friends, my family. They're such great resources to have for me as a practitioner, but also I can only imagine how many people they have helped.
Oh, that's really sweet. Thank you.
Oh, you're welcome. Thank you. So I'm a real fan of the why. I think I'm probably a 2-year-old stuck in an adult's body. And I'm not only fascinated about the why behind our health and our well-being, but I'm also really fascinated about why people do what they do, which leads me to ask you the question as I kick off. What brought you into this hormone space, from an undergrad in evolutionary biology to your naturopathic doctorate and now women's health and hormones? What was the evolution?
Yeah, it's a great question. And I have a new discovery about that, actually, the discovery. So as you mentioned, I trained as an evolutionary biologist. And this year, I actually made a bit of a pilgrimage to a science research center that I visited, that I, did an internship. I was there for 6 weeks, 30 years ago. It's where I met my best friend, and we went there together, and we were just kind of diving into that. And I found some of my a couple papers that I wrote as part of that training. One was like an original research paper, and they were, back then, as a biologist, I was really interested in sex differences and female physiology. And I wrote these, and I was fully expecting to see a paper that I wrote at 22 years old being just like not very good at all. And it turned out, I was like, that's really interesting, like looking at female physiology. So I can see that curiosity about female physiology was there from the beginning, before I became a naturopathic doctor. So then after that, trained as a naturopathic doctor. I almost went down the science path and then decided, no, I want to work with people. So I trained as a naturopathic doctor in Canada. Obviously, I have a Canadian accent. I don't know if you mentioned that in your bio. You might have, but this is, if anyone listening, they're like, where is she from? So,
sounds awesome. Sounds good.
Yeah. And, so early on, I started out in general practice as a naturopathic doctor in Canada and just treating all kinds of things. But then, of course, it's a lot of women that come looking for solutions. And back then they certainly were. That was 25 years ago, because they were just, as you can imagine, not getting answers from anything else. Those were the days of lots of surgeries, high dose birth control pills. In some ways, it's not that different now, and they were just looking for other solutions. And so I discovered that some of the tools I'd been given in my naturopathic training worked really well for period problems.
Awesome.
And I put that through the lens of biology and just thinking, this makes sense, because female physiology is a normal physiology. It's like arguably, the default version of being a mammal is being female. And we've always, unfortunately, medicine has had this narrative that period problems and female hormones are all kind of a side issue, sort of in the too hard basket. And that's why we need to just routinely shut it all down with the pill, because it's just too complicated. And so, of course, from my lens, it's like, no, that makes no sense. Like, women's bodies respond to some pretty basic things, often nutritional strategies. And it sort of went from there. And of course, I've had the opportunity to work with patients for 25 years and get to find out from them what works and what doesn't work and get their stories and get their feedback. So that led directly to my books and just thinking I need to share this information with more people than actually, the funny thing is I actually wrote the books originally just for the first book, Peer-to-Peer Manual, mostly for patients. I was like, mostly for the people coming to see me. I was like kind of a book of, we'll read this first and then we can build on that. And then of course it's done very well around the world, which is a nice bonus.
It's an amazing bonus, but it's also that it came from your own clinical practice for wanting to care for your own patients to go, right, let's start here and then we'll do the extra for expert stuff with my guidance on top of that. That's incredible. I have to say my heart sank, as you said, about like shutting things off because it's just a,
I know.
It's a secondary problem and whatever, too hard basket. Like it's such a part of a woman's life, like the whole journey of becoming a menstruating female, and it's different for everybody. Some of us get to puberty and are like, yes, I got boobs. I'm into this, I'm finally a woman, and others get to it and go, oh man, I'm not really sure I want to wear a bra, and this period thing's quite annoying every month depending on who you are and your expectations. So I'm sure there are many listeners out there who have chimed into this today. They've seen the title of hormones and gone, I don't know much about these things, but I want to learn more. So to help our listeners understand, would you mind unpacking for me what our key sex hormones are for women, how they play a role in our menstrual cycle, and what that also means for our health and our well-being beyond reproduction and menstruation?
I might start with the last thing, kind of what our hormones mean for us. So as you were talking, I'm just thinking how to describe where we're at right now, which is we're getting very close to a paradigm shift in women's health. And it's exciting to be part of that and be witness to that happening. So I don't think it's an oversimplification just to say again that the medical narrative has been that women's hormones are not required. Like they're only to make a baby, basically. Like they're, if you want a baby, you can ovulate if you want a baby, but otherwise it's really fine to shut down these pesky periods and these pesky cycles and just be done with them until you need them to make a baby. And that is not an exaggeration to say that is actually what a lot of doctors think. Not all doctors, of course, but a lot. And it's kind of where the research has been too. And then the other side of the paradigm is actually regular natural menstrual cycles, which are what are called ovulatory cycles, or cycles where ovulation is the main event of the cycle of the month of the cycle, are important for general health and not just to make a baby, because ovulatory cycles, or natural menstrual cycles, is how we make our two main hormones, estradiol, that's our main estrogen, and progesterone. And those have benefits for general health, just like testosterone has benefits for general health in men. So one of the things I say a lot, and keep coming back to it, like to say to women that you don't need your own hormones except to make a baby would be like saying to men, you don't need testosterone except until you're ready to make a baby, which would be crazy, obviously, because testosterone is important for muscles and mood and metabolism and all these things. And that's also true for estradiol and progesterone. And the unfortunate, inconvenient fact is that the contraceptive drugs, I never use the word hormones for them, but they're kind of like hormones that are in hormonal birth control, are not estradiol and progesterone. To be fair, there is one pill that uses estradiol, but no method of hormonal birth control uses progesterone, our actual hormone, like the real hormone progesterone. They all have progestins, which are the idea. I think the narrative has been, well, that's good enough. We'll shut down your own hormones and then we'll replace them with these drugs. And it's just not okay, because for example, there are quite a number of differences between progestins and progesterone. And a lot of that's to do with how progesterone is really good for the brain and progestins don't have that benefit. And another example, and this is just a small example, but all progestins slightly increase the risk of breast cancer. Now, I do say slightly because I don't want to people to come away being scared. It's, most people who take hormonal birth control will not get breast cancer from it. So just to be clear, but all progestins slightly increase the risk, whereas real progesterone probably decreases the risk of breast cancer. So that's one example of a difference. And there's a whole list of differences. So this has been kind of the elephant in the room. Every couple months now, you see another article. They're saying, wait, why do 100 million women take the pill? And we're just now starting to ask how it affects the brain, or, so that we know, for example, that women on the pill have different brain structure than women who cycle naturally, and an increased risk, arguably, of anxiety and depression. And so this is obviously all stuff that we should have known 60 or 70 years ago when we started routinely giving it to women. But we're having to figure it out on the fly and a little bit later. And yeah, so we could go from there. I don't know what your next question is. I mean, obviously this is a big topic, and
huge topic.
Yeah.
Huge. And that whole sort of segment you've just dropped is a huge bomb for anyone listening who hasn't heard this before, to understand that your own production of hormones is not any form of hormonal contraception in a large scale, right? They're different. Yeah. It's like square peg, square hole versus round peg, square hole. It's completely different in terms of how they operate in our body from a receptor point of view, or from how they influence our health and our well-being. I don't think women know that. I think they think I'm just adding in some my own sort of supply so I can control it and not have to deal with my period if I want to shut it off. That's how a lot of young women think about it, which to me is devastating when you know how good it is for the system.
Yeah, devastating is probably a feeling that I share on this. I'm pretty worried collectively about the health of women. We're on our third or fourth generation of doing this now quite routinely to women. And there's some worrying things. But I mean, again, I don't want to scare people. Look, I guess I would say, all of this said, I'll say that at this point, people are resilient. I have many patients who've been on the pill for 20 years, and they come off and they get their own cycles going. And, it's like, you're going to be okay. This is not about, panicking, but it's just sort of trying to shift the conversation to say there is value in our own hormones. And there are differences too in types of birth control. So I might just kind of talk through that a little bit, because because it can be kind of confusing if you're just not really thinking about this. But so the combined pill, which is the one with a synthetic estrogen and a progestin, it pretty much entirely shuts off progesterone. So I think it suppresses our own progesterone by 99 point something percent. It mostly suppresses our own estrogen. It essentially puts the body in temporary chemical menopause, which sounds dramatic, but it's accurate. It's temporary. It's reversible, obviously. And then it gives back these contraceptive drugs, which are actually not even as nice as modern menopausal hormone therapy. One thing that happened in the background is most menopausal hormone therapy now is body identical or bioidentical, is using actual estradiol and real progesterone, which is that's a topic for a future podcast. But that was something 25 years ago.
That, by the way, future podcast.
Yeah. Exactly. 25 years ago, naturopathic, as a naturopathic doctor, we were prescribing natural hormones, and that was considered pseudoscience and completely crazy. But of course, now, fortunately, for what it's worth, mainstream has really caught up with that. And most menopausal hormone therapy now is natural, which is amazing. So that'll be for the next podcast. But circling back to young women, don't get body identical hormones. They're given these, as we've described, drugs that are different than our own hormone. So on the combined pill, going back to the types of pills, on the combined pill, ovarian function is suppressed pretty much entirely. And then a withdrawal bleed is induced monthly. Now, there is no medical reason to do that monthly. That is not a period. So that is not a menstrual cycle. A menstrual cycle is approximately monthly because that's how long it takes to ovulate and then have a luteal phase and go through all the phases. Whereas they really only do it. It's like an advertise. I don't know what the word is. It was to sort of convince women and doctors and sort of wink, wink, this it's just regulating your cycle. You're still having a monthly period, but there's zero medical reason to do that monthly. So, which a lot of that's actually the point that a lot of women that I talk to feel quite betrayed by that. Like when they find out that, especially if they've been put on the pill to regulate their cycle, and then they find out it's actually not doing that, and there's no reason to think if you had an irregular cycle before, and then you induce regular withdrawal bleeds from those drugs, coming off the pill you're going to go back to the problem of having irregular periods. It hasn't fixed anything, and arguably in the case of PCOS, it might have worsened the underlying problem possibly, but. Right. So staying on my topic of types of birth control. So that's the combined pill, withdrawal bleeds, fake periods. Progestin-only methods, which would include implants, mini pill, progestin-only pill. They allow some estrogen. So they generally do suppress ovulation, but you're getting some estrogen. So you end up getting these sort of, they can be regular, they're usually irregular, but they're bleeds. They're what are called anovulatory cycles, which we can talk about a bit more today. It just means no ovulation happens. So in that case, it's also not a true menstrual cycle, but it's just your estrogen going up and down and getting a bit of shedding of the uterine lining. So it's not a real period, but that's what happens on implants and progestin-only methods. But the third type is the hormonal IUD, which is different again, which I always do kind of mention separately because it's an interesting thing in that with the progestin IUD, so Mirena or Kylena, the brand name just depends on the dose of the drug. It's the drug. The progestin is levonorgestrel, which is actually quite testosterone-like, which is why that particular progestin can, in some women, cause skin breakouts and hair loss, sometimes weight gain, because male-type hormones in women can cause weight gain. And but with the hormonal IUD, it's a lower dose. It's delivered locally inside the uterus. And some women can ovulate with that. So, it's still, obviously, it's an effective contraceptive agent because it's working by actually thinning the uterine lining and preventing something called cervical mucus or fertile mucus. But so it's highly effective for preventing pregnancy, but it can allow ovulation, which is really interesting from the point of view of our conversation today. So you potentially on the hormonal IUD, those are potentially real periods. If you're getting any kind of bleed coming through, you're potentially still ovulating. So to compare and contrast, on the combined pill, women bleed but don't cycle. Right? Because it's not a menstrual cycle.
Yeah.
On the hormonal IUD, it's possible to cycle and make hormones, but not bleed.
Right. Interesting.
Which is very interesting.
Very interesting. And you don't get the education. Like I remember as a youngster wandering into like a fertility, women's hormone clinic, and you kind of have permission to wander in and ask for hormonal contraception. You sit down and someone's like, here's the smorgasbord. Which one would you like? Do you want the injection? Do you want one in your arm? Do you want one put up there? Do you want to take this kind of pill, which you can kind of take within this window of time frame in your day and it'll still work? Or this one that you have to take exactly, roughly the same time each day? Which one would you like? And you're like, you don't know anything about my health, my history, what I'm going through. Didn't ask me if I had a period. I might be of age, but what if I don't?
Yeah.
What does it mean for me? So I found it really eye-opening as a youngster. And I think I walked out with a packet of condoms being like, I don't know. I just know. I can't decide. I have not enough information.
Condoms are great, by the way. Can we just take a moment to acknowledge condoms?
Yes.
So, so when I was a teenager in the 80s, we used condoms, and that was definitely a thing. Like that was a way to avoid pregnancy. And what I'm hearing from some young people, some of my patients, and there sort of seems to be this new narrative that condoms don't work or they're not a standalone method. And I just want to say they are. Like condoms, especially if you get one that fits, like a good quality condom and one that fits. I just keep emphasizing that there's some new brands that have different sizes, which makes total sense. If it fits the man properly, it's less likely to slip or break or anything like that. And then, for anyone listening who's got young, teenage daughter maybe, or sort of wondering, well, what about young people? It's like, surely they need to be on the pill. It's like, well, actually condoms plus I would couple that with easy access to Plan B or whatever we call it here, like the morning after pill, like in the unlikely event of a condom mishap, because I mean, mishaps are, if you use them properly and they're good quality and they fit right, hopefully are going to be rare. It's a rare event. But if that does happen, then one way to think about it, like the morning after pill, that's levonorgestrel as well. That's just like a big dose of the pill. It prevents ovulation. So in my thinking, it's like if you have to take that, once every 2 years rather than daily, that's a win. And it's funny, this sort of idea that, well, surely young people need to be on the pill because they're so irresponsible. But actually, it's young women, young people that actually need to be cycling naturally and establishing their natural cycles for bone density. So here's something that's one of the troubling things in the research that we're starting to see is that girls and young women who've been on the pill, the combined pill, some of the other methods as well, are not gaining their peak bone density. So I don't know if your listeners will know peak bone density is, so around 25 or 30, we have the strongest bones we're ever going to have. And it's kind of all downhill from there. I mean, it's so slow, like we slowly lose bone density. We lose bone mass from that point, but hopefully we've got enough to take us to 90 or something. But yeah, to have missed the opportunity to build bone is concerning. And that's because, like, circling back to your first question about the hormones that we make, so estrogen and progesterone, they both have many benefits. And a benefit of both of those hormones is bone building. And that's another difference. So progesterone seems to be bone building, whereas progestins are not. And you just don't, apparently on the pill, you just can't get the dose of synthetic estrogen that you would need to build bones the way exposure to natural estrogen.
That's really scary in the sense of when you think about the risk of things like osteoporosis in menopause, let alone having not had that foundation earlier on in life. Then once you hit that peak, it's like, well, there's growth hormone starts to slow down. Our opportunity for building becomes slim. And also then you add pregnancy to the mix and the use of calcium and bone stores to build a baby. You add that into the equation, it doesn't create a great trajectory for women's bone density long term. Which I remember having a friend of mine, she's probably in her late 50s now, but I remember her at sort of age 40. She had osteoporosis from a number of medical complications when she was younger. She had a button shirt on. She leaned over a couch and cracked 3 ribs.
Oh, yeah, no, it's, to be fair, osteoporosis is a scary condition. There's lots of factors, to be fair, there's lots of different factors, but having a good level of our own estrogen and progesterone does seem to be quite good for bones. So,
definitely, very helpful, very helpful. What about the injection? The Depo Provera?
Yeah, well, so Depo, what's interesting, I'll just share with you for what it's worth. I had almost never seen it in Canada or Australia, because I practiced in Canada for 5 or 6 years and then Sydney, Australia for a decade and a half, and with one stint back in Canada, working as a naturopathic doctor there again, kind of in the early 2012 kind of time. And it wasn't until I started practicing here that I was seeing more. It's used here a lot more than Canada and Australia, for whatever that's worth. And one of the reasons it's not popular in the other countries is it does carry a stronger bone risk than other types of exactly the topic we've just been talking about. It suppresses hormones to a greater degree than some of the other types we've been talking about. And it also doesn't replace estrogen. So even though, for what it's worth, the synthetic estrogen in the combined pill does still give some estrogen type benefits. So especially around bone. I think it's not enough to make up for the estradiol that women have lost, but it's still... So I think that's one of the mechanisms. I mean, they've been known about this for a while, that Depo Provera is not good for bones. And obviously the scientists are trying to kind of work out what that means. And when you stop it, like, how quickly can you go back to normal? So yeah, it's not my favorite method, but mainly for the bone reason. I would think it's there's some other research that it's actually for weight. Some women can get what the researchers call, quote, unstoppable weight gain on Depo. So by unstoppable, they mean like some other methods of hormonal birth control can cause weight gain, but it tends to sort of bump up and then plateau. Whereas with some women on Depo, it just keeps going up and up. And that's something to do with the and the nature of that progestin. It interacts with cortisol receptors, and it probably seems to impair insulin sensitivity. So anyway.
Yeah. I would say from clinical experience, it's probably the hardest form to transition somebody off. And I think it is an option, and it's often an option that is recommended when there's a history of maybe polycystic ovarian syndrome and endometriosis in the family. I've seen a couple of cases like that where people have had it pretty much just on repeat since they were like 15. And it's the physiological change, mind-blowing.
So one thing to say for all methods and young women, younger, so 15, it's pretty young, but I mean, certainly there's now the situation of girls being put on some method of hormonal birth control at like 13 or even younger. And that's very different from when the pill was first invented, when it was just like, it was for married women originally, and you take it between babies or something. Like you take it, you have your baby, and then you take it for a couple of years to kind of, and before you decide to have your next baby. And so some of the, that we rely on these, it's like the statement is like, oh, well, research has found that, the pill doesn't interfere with long-term fertility or menstrual regularity. So the idea being women could take the pill, come off it, and their periods bounce back and they're fine.
Mm-hmm.
But the only research that's been done on that really was done on older women, like adult women taking it for a while, like for a few years. But it's as you can imagine, it's a very different situation to put a 12-year-old on ovarian suppression, because it actually takes us, this is just an interesting statistic. The citation is in Period of Prayer Manual. I got this from my colleague, Professor Geraldine Pryor. It takes 12 years to mature the menstrual cycle. So from when it makes sense, because the communication between the brain and the ovaries is calibrating. It's figuring out, how do we do this? How do we ovulate regularly? How do we make these hormones? And so if you get your first period at 12, usually you're not ovulating straight away. Those are, again, another example of anovulatory cycles would be those first few cycles. That's often why girls that age can have heavier periods, because there's no progesterone coming in yet to lighten periods. So by maturing the menstrual cycle, that's ovulation happening, progesterone being made. It takes about 12 years on average to get to a good, robust, regular, strong ovulation and a good level of progesterone. And so I still remember where I was sitting. I heard Professor Pryor on a podcast. Like I was listening to a podcast. I was getting my hair done, and I heard her talk about that. I still remember exactly where I was sitting when I heard her say that. I thought, oh no, it made sense to me as a biologist, but I'm like, this is very concerning. And then the interviewer, of course, asked her like, oh, well, what does that mean for girls that are put on the pill at, when they're like 12? And it's like, well, it means when they stop the pill, eventually they're going to have to resume or begin the process of maturing their menstrual cycles. So it's not unusual in that case to take a while to get ovulation to happen. Like you can't just expect your body to just boom instantly. It's never ovulated before in its life, really. It's like, just know how to do that perfectly. Like that's a very unrealistic expectation. So one of the questions I ask my patients all the time, if they're wondering about what is it going to be like to come off Depo or the pill, or what's going to happen with my ovulation, with my cycles, I need to know, how many years of regular natural cycling did you get under your belt, if any? Wow. Like, I've had some patients, it's like, well, it's like I said, I think you've never ovulated in your life. Like, I think you've never had a natural cycle. Like, you might have had a couple bleeds when you were 13 and they were painful, so they put you on the pill, and then you came off, and then you had IVF and had a pregnancy, which is great. But like, there was never a time. I might be looking at someone in her late 30s who's never cycled.
Wow. That's huge.
And even then, this goes back to what I was saying about the body's resilience. Even then, even in that situation, they can often sometimes, get cycling going. So the body wants to ovulate. It wants to be healthy.
Our bodies are so resilient.
Resilient. They are. They really are. So this is one of my things, is trust your body. I mean, in almost every situation I would say, in most situations, you can get close to a regular, symptomless, natural period. Obviously, there's limits to that. Like, obviously, perimenopause is a limit. Like, you can only ovulate regularly up to a certain age, and then our biological blueprint is we're not going to be able to do that anymore. That's a reality. Some other realities are, of course, endometriosis and adenomyosis. I mean, there are those disease states which can, create a situation of pain and menstrual distress that is, we just have to be realistic about some of that. But even then, even with endometriosis, many times it's possible to achieve pretty close to pain-free periods, natural periods. So even if, for everyone listening, like you've had some horrendous periods in the past or irregular periods or whatever they were, and you were told the pill is your only option, I'm telling you, that is often not the case. Like, there's so many women who've found another way, who have trusted been able to reclaim what their body wants to do, which is to have natural cycles. So, yeah.
Message of hope. It's always possible, right? There's always possibility towards health with the right things at the right time. Yeah, definitely. So with, I guess, that in mind around coming off a form of hormonal contraceptive, what would be the key things that you would recommend somebody do in preparation for and then afterwards to optimize?
Yeah, I think the main thing is audit your situation. Like, take stock of what is the situation. Like, by situation, I mean, I guess I just mean, did you ever have natural cycles in your life? Like, what was the underlying, how likely is it for you to expect to have regular cycles when you stop the pill? Keeping in mind, pill bleeds are not periods. So you can't, get women saying, oh, my period became irregular when I stopped the pill. It's like, well, those weren't periods. So if that was on the combined pill, so that means, you're going back to, you're removing the suppression of your ovaries, and you're now asking your ovaries what they can do. So first thing is, in terms of, are there going to be irregular periods? It's being kind of realistic about that. And was there a problem before? And do I need to try to work out what was causing irregular periods before? So that's part of taking audit of this, stock of the situation. The other thing is, was there severe pain or premenstrual mood symptoms? Like, were those present before you were on the pill? Because they are probably still there. And so it's about being kind of prepared for what that might be, maybe putting in place some strategies for those, not being surprised by those symptoms when they reappear, like being mentally prepared for them. And I guess, again, I think in many situations, those symptoms can be improved to a great degree, but you just need to kind of know what's coming. Another thing to know what's coming is the post pill. So post Yasmin or Diane or Brenda, I'm trying to think of some of the brand names here. So any of the pills, combined pills that contain either drospirenone or ciptorone, these are a couple of progestins that are anti-androgen. So especially the ciptorone ones that's Diane. I guess there's other brand names here. Like, it really suppresses androgens or male hormones in the body. So there is this observable rebound androgen or kind of rebound testosterone effect that can cause post-pill acne or post-pill breakouts like you never imagined possible. Like, I've had patients who are like, my skin used to be bad, that's why I went on this pill as a teenager, and I tried to come off in my 30s, and I had no idea my skin could get that bad. And so that is partly the effect of, that's mainly the effect of trying to withdraw from that drug. And so I did a podcast about that. I think that's about putting in place some realistic expectations, some strategies around that, knowing the timing is your skin's probably going to be at its worst 6 months after stopping it. There's usually a honeymoon period of about 3 months where you're like, oh, maybe I'm fine. And then, oh no. And so, and then the skin comes. Yeah. Sorry?
Yeah. The kid's skin's clear coming off, and then sort of a point where the body is like, actually, by the way, here we go. Rebound effect. Yeah,
here comes the skin. So that could be hair loss too. So, but the breakouts are the ones that, and I know some of your listeners have had this. So it's just, but of course, as women, we think, oh, I must be broken. Like, obviously something's really wrong with me. My hormones are really bad. I must require to be on the pill long term. But if you kind of reframe it and say, actually, your body's doing its best. It's trying to withdraw from this medication. It's dealing with this abnormally high androgens or male hormones that is likely going to be temporary, and that you're going to come out the other side of that. So it usually peaks around 6 to 12 months. I'm sorry to be the bearer of bad news around the long timeline on this, but some women struggle with that for up to 2 years after coming off the pill. And if you
you're prepared for it, it's sort of forewarned is foreharmed conversation with people. And it's that informed consent about what you're going to do and how do we help you with that going forward.
Absolutely. And also there's treatments you could do. I mean, some natural treatments to try to mitigate that. And a lot of my patients, as long as they can dial down the breakouts by like 70 or 80% and also know that there's an end in sight, then they can persevere and get through.
Yeah.
Like skin is actually one of the most common reasons women retreat back to the pill because, and understandably, like it's
psychologically devastating for people.
Yeah. It's not nothing. Yeah.
A hard thing to show up, and when your face is covered in things and you're sort of very self-conscious, which adds to the anxiety often for people around it, which adds often to the equation in itself. So yeah, it's totally understandable. And I think I find it amazing how many women I've seen in clinical practice have come to us because of that. They're like, I've come off the pill, I want to have a baby, but I cannot deal with this acne. I'm almost ready to go back on, but the baby thing is trumping the skin at the moment, just like this much.
Well, another thing too is pregnancy will usually improve skin. So, I mean, there's that too. So, I mean, that's another incentive, I guess, but also it won't last forever, but it could last 2 years, which is really brutal. I know. So my preference would be that my preference is don't put young girls on the pill for skin. Like why not when they're 13, if skin's the problem, give them some zinc and, get them off like really sugary foods. And most young people, their skin responds quite well actually to some pretty simple things.
Even just added water,
just things like that. Yeah.
Yeah, so interesting. So on that note, I realize we're running out of time. There's so much more I could dive into with you. We could be here for hours, I feel. What are the 3 top things that you would recommend to anyone listening to this right now to help with their health, their well-being, and their hormonal health in particular?
I saw that in the list of questions. Yeah.
Such a hard question for a pracky to boil it down. But
well, it is because there's no one size fits all, right? So it really depends on what, as a listener, like what you're sitting there, what you're dealing with. Like 3 things. Okay. I'm going to say the two simple things, and then I'm going to say one more complicated thing that I want 5 minutes to explain. Because so 2 things would prioritize sleep. Don't underestimate how important sleep is for everything. So schedule time for it. Get off your phone, all those things. I will say magnesium is. Yeah, I mean, I had this funny review of peer-to-peer manual on Amazon. She's like, the book's pretty good. It basically all boils down to take magnesium, but there were a few other points. I'm like, yeah, that's fair. That's fair. It's like an 11-chapter book, but because it's so good for the nervous.
All my work, magnesium.
Yeah, exactly. It's the nervous system, and insulin. Anyway, metabolism and magnesium is good for all those things. Okay, the third thing, when it comes to period problems, is try, and it's sometimes hard, it's easier said than done, to get the right diagnosis. And
amen to that one.
There's a misdiagnosis problem going on in a few areas of women's health. And I guess one I want to speak about because this is my opportunity to reach your audience for this. So this is to do with PCOS. And a lot of women, unfortunately, being told they have PCOS when they don't. And conversely, to be fair, there's also women who definitely have PCOS and are mistakenly told they don't have it. So it kind of works both ways, but it's all to do with the ultrasound. Having so-called polycystic ovaries on ultrasound does not mean you have the hormonal condition PCOS. It's such an important thing. And a very specific time when this is a situation when this is really playing out. So it is possible to have irregular periods or lose your period from undereating. And I'll just say that again. A common reason to lose your period or have irregular periods is from not eating enough or being low carb when you shouldn't be, or just generally undereating for whatever reason, restricting your diet. And it is not uncommon, in fact, pretty common to have so-called polycystic ovaries in that situation. It just means you have ovaries that aren't ovulating. They have lots of little undeveloped eggs. They're not cysts anyways. I mean, just to be for everyone listening, ovarian cysts are a different thing. You can have a big painful ovarian cyst. There's lots of different types that might require surgery sometimes. That's a whole separate, totally separate topic from what we're talking about now. But what happens is if you have long cycles, irregular cycles, or no cycles, and then someone sees polycystic ovaries on ultrasound, if they tell you PCOS and that's not what you have, and then you Google PCOS and you just realize you're supposed to go low carb for that, and you've already lost your period because of undereating,
Not eating enough.
You're never going to get your period. And like, this sounds like it maybe shouldn't happen, but it totally happens a lot. So that's, what I guess particularly on that, I would say maybe check out some of the stuff I've written about that. Really think about what is the reason I'm not ovulating regularly, because ovulation is how you get a period. That's even if obviously ovulation is to make a baby, but even if you don't want a baby, if you want natural cycles, you have to be able to ovulate to do that.
100% agree. I cannot tell you how many people we see in clinical practice chasing fertility or hormonal well-being, just not eating enough.
Women need a lot more food than we've been led to believe. And actually women of reproductive age need quite a bit of food. So one other thing is that menopause, we need less food. So that could be for our next podcast. But
yes.
When you're trying to have periods and trying to make babies, then you need quite a lot of calories, which is not to say, some women do have PCOS and something called insulin resistance, and they've got a very different situation going on, and they don't want to undereat, but they may need to avoid really sugary foods or balance their meals, have lower GI and all that. That's fine. So that does exist, not to belittle that, or diminish the importance of that. But I just know if your audience is anything like my patient population, I guarantee some of you are undereating and don't realize. So,
100% agree. 100%. Oh, thank you so much for sharing everything today. I really appreciate everything that you do. And in the words of Dr. Seuss, unless someone like you cares a whole awful lot, nothing is going to get better. It's not. So thank you so much for caring for this community and for women in particular, our health, our well-being. It is, it's a game-changing message to give to women and a game-changing step for this space. So thank you for your time.
Thank you.